From Redfield Medical Direction, I'm Lin Wynn, Associate Medical Director, and this is your May 2025 EMS Protocol Review. This month, we'll be going over end-tidal CO2, which happens to be a real passion topic for Dr. Redfield, so we'll have him on to talk all about it. So Dr. Redfield, first question I have for you in this very special edition of our monthly protocol review is, how old were you when end-tidal first came out?
Jesus, that's a loaded question there, bud. So I remember end-tidal, my first memory of it was about 2008-ish, I think.
And when were you just finishing high school? Where are you
Yeah, and
where are we in your career?
I think I transitioned into medical school and started to realize there's some data out there with it. Um, and then, all that data comes out of ORMC out of Orlando, actually by Dr. Sal Silvestri.
So this is pretty relatively new. Like, they didn't even teach this in medical school.
Definitely not in my med school, and I think actually you went to the same med school as me. It wasn't really big out there at that point. And the interesting part about this is that anesthesia knew about this for years and never told anybody about it. And it was that famous study out of Orlando that kind of broke it out into EMS. And what I've seen in my career is that EMS has kind of been in the forefront with end-tidal CO2 with multiple uses.
So let's start with the basics. What would you like our medics to know about end-tidal?
The question is, yes, you got to know is what does end-tidal actually measure? And do we actually understand what it measures? And a lot of people just, you kind of look at it and just, oh, it's a number. And it's not just a number. It's actually two key things that it measures. First thing is ventilation. And that is the one thing we kind of learned from anesthesia is that if you have good waveform, you know you're ventilating the patient. And prior to that, we didn't have great ways really to confirm ET tube confirmation. It was always, oh, I saw it go in, it has a miss in the tube. Yeah, maybe colorimetry, but there's things that can make that be a false positive or a false negative. So that was kind of the big game changer. And when you understand that end-tidal measures ventilation as well as perfusion, you kind of understand where we need it. So obviously with ventilation, we're looking to see, is that tube confirmed? But also, if you look at the waveform patterns, what are we looking at, right? And you can decide between, is it a restrictive airway disease process or is it a pump issue? So COPD versus CHF.
It's interesting that you mentioned CHF and COPD, since there seems to be a lot of hype recently around the idea of medics using ultrasound in the field to differentiate between the two. But it sounds like we can use end-tidal, which we already have available, to do the same thing. Can you explain a little bit more about that?
So for me, the first thing is for restrictive airway disease, you're going to typically see that shark wave fin pattern that we all see, thinking about Jaws swimming in the water and you see the wave. The other thing you're going to look at is usually these people typically are CO2 retainers. So your CO2 should be elevated in that cause. So you get that, patient that's kind of has COPD, potentially CHF, that big guy, and you try to figure out which way to go. Can't really hear lung sounds because he has so much obesity. That's the tool they can use to say, you know what, this is actually COPD, asthma. I want to treat it with, your typical steroids, your NEBs, plus or minus MAG, depending on what you believe in the research and along that lines. But so then you just go the opposite of that, right? So what is a CHF going to look like, right? Typically, you're going to see a normal end-tidal CO2 waveform. But again, the other thing about this, now we're going to switch not to the ventilation aspect of it, but now you got that, that side of it, which is perfusion, right? So what would we expect? Well, somebody in CHF typically has a poor ejection fraction. So that means your pump's not working well, hence perfusion is going to be low. So instead of having that high end-tidal CO2, you're going to have that low end-tidal CO2. That way now you're sitting there saying, no, what, I'm actually going to go more down the aggressive CHF pathway. And that way you're kind of picking the treatment you're going to do and following the right pathway. When you start mixing both CHF and COPD, you're kind of actually battling against each other. And I see a lot of medics that they just kind of don't want to make a decision and kind of sit in the middle, and they're actually really not doing anything for the patient. And I'd rather have that medic make a decision, say, hey, I thought it was COPD because of X, Y, or Z, or I thought it was CHF and I went down here. Now, I'm lucky because I'm in the ER. I can get, I actually have past echo reports. I have chest x-ray. If I want to get fancy, I can look for curly B lines on ultrasound. There's a lot of things that I can do that you don't have. But I'd rather have you as a medic, EMT or intermediate, pick a route and go with it. At least you can trying to treat the patient and try and do what's best for them at that point.
Are there any disease processes that we can use end-tidal to evaluate for that aren't respiratory?
You take a look at sepsis. How sick is that patient, right? There's some data out there that your end-tidal does correlate with lactate. Are you doing a good job in resuscitation? Is that end-tidal getting lower or higher? We can even go as far as DKA. You can actually look at patients and see how acidotic they are by their end-tidal. You can actually look to see how your treatment is. There's actually a lot of centers that are pediatric or focus on kids. Instead of getting ABGs or VBGs a lot, they'll use their end-tidal nasal cannula and monitor that end-tidal and see if it's actually rising in the right direction to see if the gap is closing. And lastly, I think kind of the big thing we also see in the cardiac arrest data is, are we getting good perfusion when we're doing CPR? Is it time to switch out? Did we just get ROSC? All these things matter. And in the grand scheme of things, end-tidal is probably our best vital sign that we have.
I agree. I love end-tidal, and because I trained in Orlando, it was actually a big part of my residency training. Despite how much we love end-tidal, it's still relatively new and not as widely taught as much as we would like it to be. And some EMS systems still don't use waveform capnography. Would you say that those systems are dangerously behind, or do you think there is some excuse for that, like they are under-resourced or rural?
I would say right now the standard of care is that you need end-tidal at least for ET tube confirmation. Now, getting to the other things that we discussed today, I would love it to be standard of care. I want, if that's my family member, to have it be used on them. But it's kind of hard if you don't have the training and understanding of it to actually use that information. So I don't think it's standard of care yet for all that other stuff. I think we'll get there. There are some things with end-tidal that kind of grind my gears. And I guess I shouldn't talk about it now. One of the things that drives me crazy is that for some reason, EMS sometimes was like, I don't trust my end-tidal. It clogged. Oh, I don't see the waveform, whatever it is. And I'm like, guys, this is probably the most trustworthy thing we have. You take a look at oxygen saturation, it's 4 or 5 minutes behind. Like, how can you trust that? Your patient is sitting there for 5 minutes. So much can happen to them. You take a blood pressure, right? We don't have A lines, right? Some air surfaces might have it, but ground, typically we don't have the A lines that are measuring blood pressure from second to second. Again, 5 minutes, a lot can change in that. End-tidal, right away, you know exactly what it is. It doesn't lie to you. The last one I want to mention about is the whole ET tube thing. Is they always sit there and say, "Oh, the end-tidal was clogged. It didn't work." Well, first of all, set it up correctly where there's other barriers in place so it doesn't get clogged. But second of all, if you don't have a waveform, you got to pull the fucking tube. It is not in. And lawyers are starting to look at this, and I can't stress it enough. No waveform, no tube. I don't care about the number in these patients when you're trying to do ET tube confirmation. I just need that waveform. Some good advice on this, guys, and I stress with all my crews as well, is you need to confirm the tube, but when you hand that patient off, make a special effort of showing the doctor, the nurse in the room that you sign out to, say, hey, I got waveform. And then whatever monitor you have, make sure you hit an event or whatever it is that marks it so you get a good waveform at time of handoff. As we all know, shit rolls downhill. They're going to blame you guys if a tube gets displaced. And if you can't prove that you had end-tidal when you handed it off, guess what? You're in trouble.
So you mentioned colorimetry earlier, and I've definitely worked at some of those places that you talk about that don't have end-tidal. But what would you say to the providers who claim that they don't need capnography, they don't need that end-tidal because they can just hear breath sounds or the colorimetry turned purple?
I feel like those are the same people that don't use a bougie, right? Because they don't need it. And we all know that all the trials that look at bougie use, especially in EMS, you have better first pass success rate with intubation. And it's actually quicker in the more difficult cases. And we as EMS providers need to do a better job of understanding what is here now so we can progress for the future to do more advanced things with it. I'm talking ERs, anywhere, ICUs. If you have end-tidal, you have to be using it. So if you're in a place that's not using it, whether it be hospital-based, EMS, anywhere else, that is not acceptable at this point.
And there you have it. That's all we have for this month. This was a production of Redfield Medical Direction. Our theme music is by Infraction. As always, reach out if you have any questions. See you next time.